Hello, and welcome to our webinar, Telehealth and Remote Patient Monitoring. This is the third installment of the COVID Evolving Lessons in Healthcare Law seminar series. We will be looking at virtual healthcare strategies, opportunities, and compliance challenges. My name is Rick Hindmand, and I'm an attorney with McDonald Hopkins in the Chicago office. I focus my practice on healthcare regulatory, compliance, payment, data privacy, corporate, and transactional matters. Joining me today are Brian Scarpelli, Courtney Tito, and Richard Romero. Brian is the Senior Global Policy Counsel with the Collective Health Initiative. Collective Health Initiative is a pro-digital health advocacy effort focused on improving the use of connected health technology through updates to reimbursement, security, and privacy, and by demonstrating the efficacy of technology to improve care while reducing costs. Courtney is a member of the McDonald Hopkins West Palm Beach office and part of the firm's National Healthcare Practice Group. Courtney represents clients in the healthcare industry, including matters involving federal and payer and private payer audits and disputes, reimbursement, contract, corporate enrollment revocations, internal investigations, compliance and regulatory issues, as well as responding to subpoenas and investigative demands. Richard Romero is Senior Vice President of Coker Group. Richard has over 25 years of experience providing consulting, valuation, and litigation support services. For the past 10 years, Richard has assisted clients ranging from individual physician practices to large multi-state health hospital systems with issues and opportunities related to virtual care. Prior to the COVID-19 public health emergency, telehealth was expanding and showed lots of potential, but faced substantial barriers based on factors such as telehealth payment policies by Medicare as well as other public and private payers, along with state professional licensure and some related restrictions. In recent years, Medicare coverage has also expanded to remote patient monitoring and some other related virtual health modalities and technologies. With the public health emergency, opportunities to provide health care virtually through telehealth, remote patient monitoring, and related modalities have expanded rapidly as restrictions have been loosened. Soon after the public health emergency ends, many of the prior restrictions are scheduled to snap back unless there are legislative or regulatory actions. These shifts are creating compliance and related challenges for physicians and other providers who furnish care through virtual means. Today, we're going to cover a number of topics relating to these challenges, including the following general areas. We're going to provide an overview of virtual healthcare regulatory and payment flexibility during the public health emergency. Brian's going to discuss remote patient monitoring and telehealth issues relating to billing and coding. Courtney is going to provide insights on preparing for payer audits. And Richard is going to address virtual healthcare strategies as the public health emergency winds down, hopefully anyway, and related opportunities and challenges. We will be pleased to answer questions from the audience at the conclusion of the presentation today. You can submit your questions at any time during the webinar by emailing at events@mcdonaldhopkins.com. You see that at the bottom of the slides, or by submitting a question in the control panel for this webinar. We've got a lot to cover, so let's get started. When it comes to healthcare services provided remotely, people throw around various terms such as virtual healthcare, digital health, telehealth, telemedicine. Terms like these can have different meanings depending on one's perspective and background. Initially, I want to briefly note some of the principal modalities or means of providing virtual healthcare. So telehealth is sometimes used generally to encompass broad categories of using virtual or digital technologies to connect people in separate locations. Telehealth also has a narrower meaning within Medicare for payment purposes. In particular, there are substantial restrictions under the Social Security Act, Section 1834M. And these some of these restrictions include Medicare only pays for limited categories of services that has to be listed as an eligible telehealth service. And there are two significant location limitations. One being that the services have to be provided to patients in a clinical office or facility, for example, not in the home. And also the patient has to be located in a rural area. In recent years, Medicare has begun paying for some categories of telehealth services outside of rural areas, for example, in connection with substance use disorders or mental health conditions or end-stage renal disease patients. But the locations are generally very limited. And also there's a requirement to use under Medicare telehealth to use a two-way audio-visual platform. It cannot be audio only. Smartphones don't qualify. Keep in mind, these are the general requirements that applied before the public health emergency. Also, the telehealth payments were typically lower than they are for services provided in a physician practice, in a physician office. So these restrictions have all applied prior to the public health emergency. And due to these restrictions, only a small portion of services would qualify for Medicare payment. And keep in mind also that once we get through the public health emergency, a lot of these restrictions are likely to take shape again. A second category of services is audio only, which typically for phone services, when you don't have the audio visual, typically those don't get paid, except now that we're in the public health emergency that they are payable. There's also a category of services referred to as communication technology-based services, or CTBS, which is several years ago, Medicare began paying for expanded remote communication technology services. And there are several main categories there. There's what are referred to as virtual check-ins, which are a brief check-in with the patient to assess whether there's an office visit or other service necessary. There's also remote evaluation of images from established patients. Also, there's online medical evaluations or e-visits. So there's some additional categories there. And I'll also mention remote patient monitoring, and I'm just going to mention that very briefly because both Brian and Richard are going to discuss remote patient monitoring, which is sometimes referred to as remote physiological monitoring. And there's also, I'll mention care management. We're not going to be focusing on that, but I think it's important to keep chronic care management and transitional care management in mind, because these are management services that very often go together with the remote patient monitoring, that they kind of complement each other. And also there's interprofessional internet consultations, which are also allowed, which are a related type of service. So what we've had is during the public health emergency, we've had a relaxation of standards. And so on our next slide, we show some of the flexibilities out there for telehealth. And I already mentioned these restrictions briefly, but there have been some major changes in terms of what telehealth pays for. The technology required has been relaxed, so smartphones are now allowed, and for a lot of services, not all the services, but a lot of the telehealth services, audio only is allowed, for example, for evaluation and management visits, right? And also for some of the traditional telehealth services. The location standards have been relaxed. So now, instead of applying only if the patient's in a rural area, telehealth also pays basically wherever the patient's located, including the home. So you can have the patient in the home calling talking to a doctor in wherever the doctor is located. And there's also the services that are eligible for telehealth reimbursement under Medicare have been expanded. There've been around 140 telehealth services that have been added. And although this is kind of an interesting twist, is that there was just in today's Federal Register, there's a notice that that 4 of those services that were listed as telehealth eligible, CMS said, well, they weren't supposed to have been listed. They're really not. So that's kind of a reminder that things are very fluid in this area, and it's very important to keep track of what's going on, especially if you're relying on things. Also, the eligible practitioners who are allowed to bill for telehealth has been expanded, not only to additional classes of professionals, but also federally qualified health centers and rural health clinics. And also the pay, the differential in pay, the lower pay for providing the services, the lower reimbursement. Medicare in many cases now pays the same rate as for in person. There are also we've also got a slide that mentions some of the general flexibilities, which apply to a number of these areas. In some cases, it's telehealth. In other cases, it's the CTBS or remote patient monitoring. So there's a requirement, a general requirement, that there be an established relationship with the patient prior to the services being performed. That's being loosened, so the services can also be performed for new patients. There's a patient consent requirement, and now the patient consent's allowed at the time of service. You don't necessarily have to get it ahead of time. For some services, such as controlled substance prescriptions, there's requirements of having an in-person exam. Those restrictions have been relaxed. Some of them are on the state level, some are on the federal level. Physicians are now allowed to provide direct physician supervision via audio video, and not necessarily have to be physically in the same location where the staff member is when providing services. There are restrictions on waiving or failing to collect copays. That's basically a requirement, and now the Office of Inspector General has allowed flexibility to waive the copays or reduce the cost sharing. Also, an issue that's typically a practitioner, like a physician, is required to be in the same state where the patient's located. For Medicare purposes, that's generally being waived, and a lot of states, or some states anyway, are doing the same thing. But you have to look on a state-by-state basis to see whether that relaxation applies. And I'll mention a couple things for remote patient monitoring, and I think Brian's going to discuss RPM in a few minutes. There had been a requirement that it applied only to chronic conditions. It now applies to chronic or acute. Also, requirement of if there's a medical device, it has to be used for remote patient monitoring 16 days or more in a month. 30-day period, that's been reduced to at least 2 days in the month, and that's going to be temporary. That's going to end when the public health emergency ends. And also, there's an expansion of the practitioners or the professionals who are allowed to use to bill for some of these for telehealth and CTBS. Now, and then we also have some relaxation from a HIPAA perspective, which is the next slide that we have here. And I'll just mention this briefly because we're not really focusing on the HIPAA and privacy and security issues, but they are crucial in order to try to have security and to try to satisfy the requirements there. There's a temporary waiver by the Office for Civil Rights of HIPAA penalties for good faith use of remote communication technologies. Keep in mind that breach notification still applies. And there's also a OCR, Office for Civil Rights, is allowing the use of audio or video communication products that are not public facing. In some cases, even if they may not typically satisfy HIPAA standards in terms of security. There's also a requirement for business associate agreements. The Office for Civil Rights is temporarily waiving penalties for that as well. And then so we've got a number of issues that come up in terms of these flexibilities are going to be ending very soon, which we've got on the next slide. We've got several references on to that. But just keep in mind that absent some kind of legislative or regulatory action, whether it's the federal or state level, most of these restrictions are going to return. So the telehealth ones, for example, and there's a number of proposals that are pending, some in Congress, some at the state level. We do have just 3 days ago, and this is on the next slide, just a few days ago, MedPAC, which is issued a report to Congress, the Medicare Payment Advisory Commission, and they issued their report to Congress, and they outlined some possibilities for expanded telehealth at the end of the health emergency. One would be to temporarily continue some of the relaxations, but to return some of the other restrictions, like the patient cost sharing requirement of collections and paying the lower rate, for example. But they did note that they suggested or mentioned the possibility of collecting more cost data. And they also recommended some post-public health emergency safeguards, like additional scrutiny to clinicians, physicians who are billing a lot of telehealth, and also to require some in-person visits before ordering DME, and also to prohibit incident to services in some cases. So, and on the next slide, that kind of comes in with some issues that Courtney is going to be discussing Courtney's going to be discussing preparing for payer audits. But just keep in mind, we've got the Office of Inspector General has six different audits or reviews that they have going on right now of telehealth, and so that really shows us that telehealth is really on the radar screen. And then on the next slide, we also have some. It's also important to keep in mind the need for to develop virtual health strategies, and Richard's gonna talk about that in his segment a little bit later today. But you've got a lot of things that are coming in to expanded payment and flexibility, and this relates to like remote patient monitoring can help with value-based payment metrics. So it's really important to develop a virtual care strategy to transition from a lot of people have been reactive and maybe need to get more proactive and also prepare for the snapback. So Richard's going to be talking about that later, and I'll turn it over now to Brian to discuss remote patient monitoring.
Great, thanks. Yes, good, excellent. Well, thank you so much. Really pleased to be here to talk with you today. Very timely topic. Just a little bit about who I am and who my org is, just if that helps at all, and I won't go on and on about it, I promise. But yes, I'm Brian Scarpelli. I'm with an organization called the Connected Health Initiative. It's a not-for-profit multi-stakeholder consensus advocacy effort. You can see it says there. That's a mouthful, but we're in a Washington D.C. based advocacy effort that aims to pull together as much agreement from across the healthcare ecosystem as possible about the responsible ways to take up and use digital health tools to improve outcomes and save costs. That's the mission of the effort in a nutshell. There's a ton of different venues that we're advocating before, both on legislative and regulatory issues across a range of subject areas: reimbursement, payment, privacy and security issues, efficacy and quality assurance, the increased role of AI in healthcare, whatever that means to you, and the newest effort is related to value-based care, which is always an important discussion to have. That's probably for this slide. Again, there's a link to our org website in case anyone wants to see it there. So this slide, it has some baseline kind of historical context information, some of which I think Rick actually touched on a little bit there. But for some folks who are fortunate enough to have not been in the throes of dealing with the federal policymakers, particularly with respect to Medicare on digital healthcare issues, because of a statutory definition in the Social Security Act, last updated in the 90s, telehealth, Medicare telehealth services, they're defined in statute, and they're due to subsequent interpretation by the Centers for Medicare and Medicaid Services, CMS. Medicare telehealth services are in effect a live voice video call, and nothing else modality-wise. So asynchronous or store and forward and things like that are not included. There is an exception, of course, like there is to everything. Store and forward is considered telehealth in some pilots in Alaska and Hawaii, but let's not worry about that. The 1834M is the infamous section in the Social Security Act, which provides that definition, and you may hear people throw that around from time to time. But there was initially confusion, a great deal of confusion as to what Medicare telehealth services were. Eventually, the Centers for Medicare and Medicaid Services did very plainly clarify that only Medicare telehealth services are subject to 1834M restrictions, such as that the home of the patient cannot be an originating site of care, that only eligible patients, or that eligible patients reside in only a healthcare professional shortage area, which in effect excludes urban and suburban parts of the country entirely, and other onerous restrictions that were adopted into law in good faith by Congress at the time in the 90s, and which I argue no longer make sense, but people still have to contend with them, especially if you're offering Medicare telehealth services. If you're not, then you're not subject to those restrictions, and that's been made clear, fortunately, by CMS over time. I mentioned there's a few references here to a couple important legislative pieces of legislation that organizations like mine are very that are basically really pushing and working on. They're One was just introduced, that's the Telehealth Modernization Act, which would address, to an extent, some of those 1834M restrictions, which have just become a glaring must fix, I think. The Connect for Health Act has a little bit of a broader scope, would address some 1834M restrictions, but would also take some steps to enable other modalities of digital health, such as remote physiologic or remote patient monitoring and things like that. Okay, so yeah, just looking. This slide is intended, and again, I'm not certainly not going to take a extremely detailed deep dive into the physician fee schedule or the quality payment program, but that's the key regulatory vehicle here is the annually addressed Medicare physician fee schedule and quality payment program rule. They kick out a draft usually mid-year, June or July at the latest, and then they finalize it by November, and then it goes into effect the next year, and they do it every year. And these are in the last physician fee schedule, which we're all now living in that world. It is 2021, and it's effective for calendar year 2021. There are a range of parts in that rule that impact the digital health community. The Medicare telehealth services list which again is that kind of legacy list created by statute. CMS, that is, they've established a process for adding codes to that list. They have two categories that will always exist, I guess. One is reserved for services that are similar to services already approved for the Medicare telehealth services list. Another category 2 is for services that are not similar, and there's a review process for that. There's also a third category of telehealth codes that are added services for on a temporary basis. Those are only going to be able to be used during the public health emergency. So that is. It's a large list. There's also a couple of communications-based technology services, which provide us with a baseline definition of there that people have been relying on now for a couple of years that I think are noteworthy. The brief communications technology-based service and the remote evaluation of pre-recorded patient information. That second one there, you can think of like the dermatology use case. I think that's the classic example. Remember, neither of those are subject to 1834M restrictions, fortunately. And then the remote patient monitoring codes here, worth noting. These are there's 5 in total. There's actually one that precedes all of these, which was just a bundled code for many years and was unbundled about 4 years ago, 99091. But these 4 codes, the 99453, 4, 7, and 8, they are that's what we're looking at for remote patient monitoring. These codes were developed through the American Medical Association's CPT code process, specifically by a component of it called the Digital Medicine Payment Advisory Group that our organization is a member of that group. And 2 of them are intended to represent the technical component of remote physiologic monitoring. The first, the setup, the patient education, that's a one-time. The second code, 99454, is the device supply. That's a monthly, basically data transmission reimbursement, which if you talk to CMS, they will tell you they're contemplating an equipment leasing arrangement, basically. And then you have these 2 57 and 58 codes that represent the professional service component of it. 20 minutes or more of a QHCP's or clinical staff or physician review, and an additional 20 minutes if it's needed. And so these codes have been around for a little bit. now, for, I guess by that I mean a couple of years, and a variety of ambiguities and questions have been pointed out by the stakeholder community, and CMS has been listening to those. So when they initially activated and paid for these what was then 3 codes, 3, 4, and 7, CMS made this promise, this is 2-3 years ago, that they were going to issue detailed guidance on how to use those codes to answer questions and resolve ambiguities. And we had to wait some years for that to happen. But for better or worse, CMS has provided that detailed guidance, and they've come through on that promise in this most recent physician fee schedule. So that and some other steps that they've taken in light of the public health emergency for RPM are worth describing. And you can see here the 2021 payments, at least as proposed. And but the final rule makes for 2021 has provided us with a number of modifications and clarifications. Some of these will, I hope, I'm sure that they align with what Rick said, but hopefully we'll build on it too. After the public health emergency, during the public health emergency, an established patient-physician relationship that would be initiated by an in-person visit was required, during the public health emergency, that has not been required. After the public health emergency ends, that's going to be reinstated. There's some disappointment there amongst the community on that rule, but at least we have clarity. Consent can be obtained at the time. RPM services are furnished permanently. In fact, you could probably go to the next slide because I think I capture a few of these on the next slide. Auxiliary personnel are allowed to furnish 99453 and 99454 under a physician's supervision. That includes contracted employees, and remember that auxiliary personnel is anyone under the supervision of a physician, not excluded from Medicare, Medicaid, or another federally funded healthcare program. Also, recall that in years past, CMS has provided some clarification that remote patient monitoring under CPD code 99457 and impliedly 99458, these are the professional components, can be furnished by auxiliary personnel.
Okay, I'm sorry, my phone hung up on the audio there, but I guarantee you that problem was on my end. Sorry about that, but all right. I think what I was saying was that auxiliary personnel can furnish the services incident to the billing practitioner's professional service, and and what that's meaning is that the service is one that is performed under the supervision of a physician, billed to Medicare in the name of the physician, subject to certain requirements. But that announcement was provided in a technical correction to the physician fee schedule that was issued in March of 2019. But thought that might be helpful to mention there. As Rick mentioned earlier, important to note, CMS has clarified once again that a medical device that's part of the 99454, this is the transmission or the leasing arrangement, as I put it, component there, needs to meet the definition of a medical device under the Food, Drug, and Cosmetic Act, the FDA Act. And they have also clarified that self-reported data is not going to meet their requirement of an automated transmission. I think in practical terms, if you talk to CMS, again, I'm not talking for them, but I'm just kind of paraphrasing here. They did not want, they're not looking to include use cases such as someone standing on a scale and typing their weight in and then having that be transmitted, even if it's transmitted automatically. They're looking for FDA-approved devices that are at some interval collecting a biometric characteristic and that it's storing and forwarding it. for review. And again, we've argued for a while for a broader interpretation than that, but these are the facts here. This is what they've clarified. Also, as Rick mentioned, the requirement of at least 16 days of data collection and the transmission requirement that's gonna go back into effect. Only physicians and practitioners eligible to furnish evaluation and management services can bill for RPM. There's been a push, for example, to include pharmacists and others in that group, and CMS has resisted that once again. And another very important point that building on, just echoing what Rick said, not only are chronic conditions eligible here, but acute conditions as well. COVID-19 is an acute condition, and that is what drove it. So CMS provided that clarification actually in one of their final rules addressing the public health emergency, and they've solidified and restated that clarification. There's been a lot of activity in trying to, a lot of lobbying really with CMS in trying to influence their definition of an interactive communication as it's included in 99457 and 99458. What CMS is saying is that it's a real-time and synchronous two-way interaction that can be enhanced with video, as described in one of the two communications-based technology services codes. But I think in the technical correction that was addressed to a degree there through a slight revision. I don't think CMS intends to require live interaction to suffice under these two remote patient monitoring codes, because they recognize that would defeat the entire purpose of the codes. So have some reassurance there. And lastly, they have confirmed that independent diagnostic testing facilities are not eligible to bill for RPM services. Personally, I'm a little disappointed by that, but again, we do have that clarity.
Thank you. So we are a little bit behind, so I'm gonna try and do this at a pretty high level because I don't want to cut in too much into Richard's time, because I think Brian, Rick, and Richard are really getting into the meat of what this seminar is meant to be about. That being said, I do think that preparing for payer audits is extraordinarily important and is something that most providers are not interested in thinking about until it's too late, much to their detriment. So I'll probably skim through some of these slides. You know, if you have questions afterwards, feel free to ask during the presentation, or you can reach out to me at any time, but I'll probably go a little bit quickly through some of these. So this slide, I think, is important because it holds some really key concepts when you're talking about reimbursements from payers. Primarily, payer audits are about how do you get paid and keep that money that you've been paid. And many providers don't understand that reimbursements are wholly dependent upon the coverage criteria set by the payer. It's completely separate and independent from what a provider's clinical medical necessity determination is very different from what a payer, whether it's a federal payer or a commercial payer, deems will be medically necessary or covered within their reimbursement scheme. And you know that we've talked a little bit today about how some of those flexibilities have changed, and part of that, you know, just thinking about one of the things we've talked about is which providers are allowed to provide these services. During this PHE, those flexibilities have been granted so that additional providers can provide those services and can bill for them and be reimbursed. However, that will be excellent low-hanging fruit for the payers to come after once this PHE is over. So we've all talked about how this transition back to whatever will be in play afterwards is important, and it's important to have a plan now for how you're going to do that transition. Another really important concept is this idea of clean claims. So almost every payer I've worked with, every contract I've looked at, has a mechanism for payment of clean claims, which means if you submit your claim form and your T's are crossed and your I's are dotted and it looks like a claim that should be paid, it will be paid, which is to everyone's benefit. Insurance companies have prompt pay laws that they need to comply with. Providers don't want to have to put into a prepayment review type process to get paid on claims because that takes too long and you want to get your money. However, I have spoken with several a lot of actual clients and billing companies who take the position that if they just submit a claim and it gets paid, that means it's covered and they are safe. That is not the case. So try not to determine coverage by submitting claims and if you get paid, that means you're safe. It doesn't. All payers, the government and commercial payers, have mechanisms that allow for clawing back that money. It allows them to go back and look using data analytics. That's the most popular method right now, where they look for outliers for whatever reason. We don't know what the data points are, but if you're an outlier, you're going to need to be able to defend why you submitted those claims and why they should be covered. So let's move to the next slide. This slide just sort of lists the main issues that payers are concerned with, the general issues, the COVID-specific issues, and the telehealth issues. I'm not going to spend a lot of time on here. Note that fraud should be on all three of these. I didn't put it on telehealth because I was trying to be very specific to telehealth, but fraud is going to be incredibly important to all the payers. Moving on, I want to look at some additional things that providers need to be aware of. Definitions of medical necessity and covered services. Again, remember this is medical necessity from the payer's perspective, what they deem will be covered and what they deem is required. So look in your contracts, look in medical policies. Commercial payers have these policies online. Sometimes they're behind a portal, sometimes they're not. They can be difficult to find. Sometimes you have to ask for them. Medicare puts these policies out in the form of national coverage determinations or local coverage determinations. You're also bound, whether you're in network or out of network, to the provider manuals and the procedure guides. And remember, only one of those definitions of medical necessity is going to get you paid. I say this over and over again because it's the number one misunderstanding that my clients have when they come to me with these audits. So moving on, I want to very briefly touch on the 60-day rule. This is another obligation that a lot of our clients just generally aren't aware of their obligations under this rule. Statutorily, nobody is allowed to retain payments to which they're not entitled. So if you get paid for a service that you shouldn't have been paid for, you cannot keep it. If you do keep it, you are subject to false claims liability, which in this case, when you're retaining it, is often called reverse false claims. And if you'll recall, false claims liability subjects you to treble damages, which can make this incredibly disastrous for a lot of providers. So the obligations under this rule are that if you have credible information that you have received an overpayment, you have an obligation, this is a proactive obligation on the part of the provider, to exercise reasonable diligence through a timely good faith investigation to make a determination and identify an overpayment. It's a mouthful, but the rule, the Part A and the Part B rules set out the process for what that obligation looks like. Providers are required to basically do an internal investigation. That investigation should have a 6-year look-back period. You have 6 months to conduct the investigation, and once you identify the overpayment, which means that you both determine that an overpayment exists and quantify it, you have to have both of those for it to be deemed an identified overpayment, then the 2 months or the 60 days from the name of the rule comes into play. You have 60 days to report and refund the overpayment. And moving on, what's really important in this rule, and if we look at the next slide, it tells you in the rule there is language that says that even if you find a single overpayment, one overpaid claim, this obligation is triggered, which means you should be calling your attorneys, getting on the phone with your in-house counsel, talking to your billing companies, talking to your consultants every time you find a single overpaid claim to determine if an investigation needs to be instituted. The scope of the investigation can be limited, meaning you don't always have to go back 6 years. You don't have to look at all your claims. It's very fact-specific, so you really want to get engaged with counsel, whether it's in-house or external, to help you sort through some of those issues. The other reason, and again, this isn't meant to be self-serving, but the other reason we recommend having counsel involved is because you'll get attorney-client privilege coverage to the extent that it's available, and you want that for the investigation. Because if you can keep some of those investigative details to yourself and just provide the results, that's what you want to be able to do. This slide on the bottom of the slide has some of the ways that you can minimize the scope of the investigation or talk about how that can be changed. This next slide, I'm not going to go into it because I'm already cutting into Richard's time and I don't want to do it, but this talks about COVID-19 enforcement considerations. Be very cognizant of your obligations if you accepted provider relief funds. There are false claims liability considerations with that as well. So if you have taken PRF funds in any of the distributions, you need to be well aware of the fact that there will be aggressive enforcement here. On the next slide, I list some of the ways that audits can be triggered and the types of audits. Audits are almost always started through some sort of medical records request. This is another very critical document that is very often overlooked. It is, taken in by a clerk who doesn't understand its significance. The clerk may go and grab whatever records you have close at hand and submit them. That is not what you need to do. You need to take these very seriously. You need to have, a policy or a procedure in place. You need to have a responsible person who's going to determine what records will be collected and how things will be documented, because how you do on this records request will determine the scope of any potential overpayment. So it's really important. I mentioned earlier that data analytics are often how these are set out, is they put in data points, and for whatever reason you as a provider come out as an outlier, and you're going to need to make sure that you can defend what you've submitted. Again, I list here some of the types of audits. Fee-for-service are both commercial and Medicare. Medicare has also been instituting in the past few years different types of education audits that allow you to work with Medicare to improve your billing practices so that you can lessen your overpayments amounts and give you the opportunity to see what Medicare is really looking for. On the next one, the next two slides, I won't spend time on. These give you the levels of appeal for the Medicare administrative appeal process. It's 5 levels there. And then after that, we talk about the commercial payer appeal process. This one's a little bit easier and much less time consuming. They're often resolved with negotiations directly with the payer. I will say, whether it's Medicare or a commercial payer, they are wrong all the time. Do not take their claims analysis at face value. We overturn denials all the time. It doesn't mean you're going to overturn everything, and maybe you can't overturn anything. If it's a straight up waiver of cost share and you never billed for any cost share, you may not have a lot of options. But if it's medical necessity or something that was allowed during the PHE for these telehealth services and flexibilities, and you can establish that you followed what was in play at the time, then you need to challenge it so that you could reduce the overpayment. This last slide, and then I'll turn it over to you, Richard, is the just sort of my best practices and tips. Everything in healthcare, at least as far as Medicare and the payers are concerned, is evidence-based, which is why I say document, 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 because if you don't document it, it's as if it didn't happen. I will let you sort of read through the rest of these. And again, I apologize for the rush, but I want to make sure that I don't steal too much of Richard's time, and we still have time for questions, but I am absolutely available for questions after the presentation as well. So thank you.
Terrific. Thank you, Courtney. As we look at, so I'm a Senior Vice President with Coker Group, and I appreciate the opportunity to join everyone today. Our firm, we really deal in a multiple of areas: finance, operations, strategy, IT, and compliance. And so we primarily deal with providers in those areas. And what I think is very interesting, and right along the lines of what Courtney was saying, is we actually did our own survey of our clients and people in our contacts. And quite frankly, when we looked at the focus areas of what people were most concerned about or dealing with implementing some form of telehealth, compliance was rated the least important. And so what we're now seeing, as Rick talked about with regard to the OIG and Courtney talking about being prepared for that, we want to make sure that you're in the best position that you can. So I just want to highlight the comments that Courtney had. I think as we dive into specifically RPM and to some extent virtual care holistically, I think we ought to realize that this is a significantly growing industry, right? And we have a number of players that are participating in this, whether that be in dealing with their own patients or trying to find a more comprehensive solution to quality of care, packaging, CCM, TCM, RPM with annual wellness visits. And there's different, and we'll get into this a little bit, but the different types of way that they'll contract for those services. We understand that telehealth is benefiting a population that heretofore has probably not received the services that they have. I think a common area that what we've heard is potential inequities for access and the provision of audio-only services. If you've heard some of the stories over the last year about how valuable that's been, some of the work that Brian and other groups are doing in terms of trying to keep the expansion alive, so to speak, I think is going to be very critical for us going forward. A big comment that I'll make here is, even as we get into RPM and telehealth as a whole, is that one of the things that we should always think about is that your opportunity is also someone, as if on the provider side, is your opportunity is also someone else's opportunity. Their opportunity becomes your competitive force against you. And so when you're looking at these kind of your strategy, what you want to pursue, always understand is that you're not moving in a vacuum, and you have others that are pursuing these opportunities as well. And so it can become a very thoughtful process in terms of how this is going to affect my finances, my staffing, position, workflows. Do I have my compliance in order? And how am I getting paid for all of these things? So just understand that I've used the analogy in the past that, you know, in a given practice, you used to have you'd play checkers with the practice up the street, for example. Now you're playing 3D chess with Teladoc and Amazon, who's going to be expanding as well. So overall, we know that we've got increased scrutiny of services. Having said that as a backdrop, if you will, let's take a look a little bit more specifically with regard to RPM growth. Just a couple of key highlights. I think it's important when we talk about an industry to get a sense for where things might be going. Quoting McKinsey, estimating $250 billion in healthcare spending could shift to virtual care models. Estimated globally, it was about a $1.5 billion market, growing to $2.7 billion. Estimated 30 million US patients will use RPM by 2024. Estimated 38% of healthcare organizations are already using some of it. 24% of practices are estimated to have used RPM prior to the PHE. And kind of an interesting one I've added here is we often think of PHE as blood pressure cuffs, those types of things. Well, interestingly enough, according to Pew, at least 46% of millennials use blood pressure cuff monitoring. So it's not just, it has wide appeal, if you will. So if we move forward to the next slide, continuing a little bit with regard to use, this was a survey done in February, specifically related to RPM use. 43% of respondents are expecting that to overtake in-person or inpatient monitoring. 35% will surpass it. We've got somewhere in the neighborhood of 20% or 23% are supposed to be using it. 90% of respondents believe that 24-hour remote data collection is important when compared to episodic data. I think that's very telling, because obviously an RPM device and the system allows us to measure and provide clinical care in ways that, quite frankly, the creative folks are going to find new things to do. We'll talk about this in a minute, but we see that happening with regard to clinical research. Obviously, the two biggest, I think, keys that are cited for success is, one is obviously getting paid for doing it, and the last one is making sure that you can integrate it within your EHR. So those are big keys. I think if we can move forward on the slides. Terrific. So I want to say that I did not put this slide together. So first and foremost, and my apologies that I picked this up somewhere along the way. So I would love to give proper attribution, but I cannot do so. However, I think this is just a high-level illustration of the types of information that we can get in from the different devices. So when we're talking about RPM, here's just a quick picture about some of the data that we have, everything from weight to seizures, going from the toe to head there, and a lot of information in between. Moving on. So obviously, we are in a universe and a world of value-based care. This has been, as we look at healthcare historically, has been perhaps an overly arduous transition, if you will, within the value-based care spectrum. There's been concentrated efforts, as we know, by CMS and others to move us to that perspective. And so as we think about the benefits for RPM, it really ties in the value-based care. So we talked about continuing monitoring of patients, understanding, being able to react more quickly, and we'll talk about that a little bit more in the device selection side. But obviously, you're able to detect illnesses early on. I mean, some levels of RPM are obviously contactless, some of them are contact-based. Some of it is used just for patients in the home to identify falls, right, in terms of remote patient management, if we extend that in a greater sense. The prevention of worsening conditions, and obviously cost reductions in hospitals and reduction in obviously hospitalizations are a big one. And then two others, mobility. And I would also say, as long as there is the capacity for internet connectivity, also serving in rural markets. I think we're moving on to the next slide. Terrific. So obviously we've talked about the growth in RPM and even provided some statistics about where we're seeing this, where we're seeing the growth. So if we take a step back and say, what has really been drivers of the adoption of RPM? Well, first and foremost, I think is reimbursement. And sometimes reimbursement is just the incentive that folks need, quite frankly, to do what they would want to do anyway to provide better patient care. So we've certainly had increased reimbursement. There's also competitions for patients. As we stated earlier, your opportunities are also opportunities for others. And it becomes, in some instances, a technological arms race. What arms races do you want to get in? What patients are you going to serve? And how are you going to use RPM with regard to patient care? Clearly, we've got an enhanced continuity of care. I think that's key, and the ability to monitor patients across those different points of care. Clearly, we just talked about value-based initiatives, obviously outcomes, and we'll tie this into the following bullet point, or the bullet point at the bottom here in a second. But the other piece is the proliferation of vendors and the development of technology. I think what we're seeing with regard to the RPM devices themselves is the typical track with technology with regard to miniaturization. We certainly have wearables, consumers. I have a family member who's got a heart condition, bought an Apple Watch 6 because of the EKG capability. So some of those types of things just on the direct to consumer. But the vendors, which is really interesting, SpaceX actually had a competition years ago to develop the tricorder from Star Trek fame. And they had a number of I think it was 45 different entrants. I think the top 5, all of those finalists are actually being put into commercial development for use around the world. And so the applications of this truly are worldwide. On the clinical research side, I think the last statistics that I saw somewhere in the neighborhood of 2010 estimated around 100 clinical investigations were using RPM. Fast forward 10 years later, it's up to 1,000. And then finally, the new Stark and anti-kickback regulations that we just had that went into effect at the beginning of the year, there's a dramatic easing of, or I should say, of regulation and the presentation of value-based entities that are requiring, in some circumstances, the assumption of risk, along with targeting outcomes-based measures. How well are your patients responding to what you're doing? Clearly, that is an opportunity for RPM. So as we look at this, there's a consensus that value-based care is driving this demand. We have vendors that are stepping up to meet that demand, and we have, from a regulatory perspective, support for increased use. So on the challenges of RPM, there's always a good and a more challenging side, is the accessibility. I mean, clearly, if we talk about RPM or telehealth, the stories have been rampant. We've known that they've existed for years. Congress has looked at trying to expand broadband access. FTC for years has provided different grants. This was pre-public pandemic. We saw an increased amount of that in time, but we clearly have areas where accessibility is not there. We've all probably heard stories of patients having to drive miles to sit in during the pandemic in the physician's parking lot to be able to connect, to have those visits. So we still have that challenge. Clearly, anytime we have a new technology or a new process, and this is both, We've got behavioral change of both providers as well as training of patients in terms of adopting this. On the telehealth side, we certainly saw significant and overwhelming positive response to the telehealth visit, such that if we look at the digital engagement of patients, I think that's an expectation going forward. Device selection, we'll get into a little more, but there are, just as there are a myriad of providers, there's a myriad of potential opportunities for vendors to support and choose from. Clearly, there's a requirement to analyze the data. The data that's collected must be reliable for analysis. And then, as we keep saying again, there's also the aspect of integration with your EHR.
Yeah, and Richard, one thing that I'll just mention too is it's really important, like when you're looking at how an approach operates, especially like if you're talking about remote patient monitoring and similar concerns for chronic care management, is a lot of these services can be provided by staff members. So it can be someone who's employed directly by the physician practice, or it could be an outside company that comes in and offers these types of services to the physician practice. And it's legitimate to do things in that way, but it's important not to forget about the role of the physician, or it could be a nurse practitioner or physician assistant. Whoever bills for the service is responsible for the service, and the services end up getting very often ending up getting billed on an incident to basis. So they have to be supervised by a physician. So you have to have the physician or whoever does the billing needs to be involved in the provision of services and supervising. And so for example, that could involve some involvement of in terms of developing protocols for the staff member, or helping train the staff member, or at least make sure that training's appropriate, and periodically reviewing findings, like maybe having an approach where if certain thresholds are met, like with the reading, it gets escalated up the chain to the physician, so something can be done. So yeah, I just wanted to mention that those are important issues that sometimes people kind of may forget about that because you think about clinical staff member doing the service.
You know, Rick, I think that's a terrific point, and I think we saw from the MedPAC recommendations that came out, and again, MedPAC, these are just recommendations. They're not new regulations or law yet, but they're taking a hard look at the supervision component and perhaps requiring eliminating incident to billing, that at least for those that could otherwise bill. If you have an NPI number, their proposal is if they're providing a telemedicine service, they would have to use their NPI. Otherwise, you could, or I should say, they would not be able to bill under the physician. They would have to bill under their own NPI. Those that would not have an NPI would still be allowed to do incident too. So we've got some changes, and as Rick mentioned before, we had just some updates yesterday. I think it's a key factor to try and keep track of all of the changes. And then in the bigger picture sense that I will say is, you know, as we're talking about these things, there are changes in the operations of the practice. There's also financial considerations in terms of considering the value of your entity overall for compensation, what kind of changes do we have in compensation plan design, those types of things. So these have downstream impacts. But getting back specifically to RPM, and we talked about the selection of the device itself, and this ties into what your strategy is going to be. How do you intend to use RPM for patient care? So we want it to be able to support multiple diseases. Obviously, we need to have the real-time data of providers. It's got to be secure and HIPAA compliant. We've talked about, not the focus of today's conversation, but certainly we've mentioned that. That's just an absolute. And if we haven't made the point already, certainly EHR integration, that's a big piece of this. Courtney mentioned analytics with regard to billing, but certainly analytics with regard to the data that you're receiving. Performance and readmission rate dashboards. Remember, currently most of the RPM is dealing in areas of chronic care management. And I think tying into a comment that Rick just made with regard to automatic critical and panic alerts, where are you going to set those? And Rick talked about escalation procedures. Does the doctor get notified, or given a certain circumstance, is the patient told to call 911 and be transported to the hospital immediately? So those are some of the practical implications that you have. And then obviously some RPM also include clinical decision support aspects to their service or technology. This is more of a global, and I'll go over this at a high level. I highly recommend the source that's referenced down below, the AMA Digital Health Implementations Playbook. It's publicly available. But as you're looking at engaging in new technology, I'll just highlight these. You've got to make sure you engage and educate your patients. Device management, which we'll talk a little bit more about here in a moment. The data monitoring, managing innovations, and coding and billing. I think that is universal for any new technology. So we'll go ahead and go to the next slide. So when we look at RPM and the fee models that we have seen, and we actually work with some RPM companies and some entities that have more holistic, what I'll say is wellness type offerings, we typically see situations where a provider or practice will provide all the components of the services. Or in an alternative, they will enter into agreements with third parties to provide either the devices and software, or devices, software, and the remote and clinical auxiliary staff. A key point there is if you are entering into a contract, especially where you potentially could have some kind of clinical liability, or you're going to rely on their exercise in order to be able to bill, clearly you're going to want to have counsel review that and make sure you understand what your liability is and what your responsibilities are under those types of agreements. And generally, when we see the fee structures with those, we really see typically one of three, either a per user fee, a platform access subscription fee, or a per member per month fee, as long as that's typically at fair market value. So operational considerations here at a high level to kind of sum this up for the most part is the key point is going to be to determine your organizational RPM strategy. And again, this is what you want to do well, what you want to focus in on, but also consider what your competitors, and sometimes that requires identifying who your competitors are going to be for your patients, and in terms of the difference that you can make for them. When you think about strategy, you also have to think about your implications with regard to your practice, and that can be patient workflows, staffing, shifting of personnel to different roles, and then on a go-forward basis, depending upon what happens with, for example, telehealth reimbursement, how much of your business do you want to have in person? Early within the pandemic, I think, or perhaps halfway through the year last year, I think 15% of providers said they had planned to reduce their physical office space going forward. Device logistics. This is one of those, yes, we're talking about the devices, all the great things that they can do. Okay, foundationally, where are you going to get them? Who's going to get them to the patient? Who's going to confirm receipt? How are you going to make sure when the recording is over, recouping the device, refurbishment of the device so that it could be used again? Those are some of those questions you want to make sure that you understand, especially if you're using a third-party contract. Vendor selection, we've talked about some of the things that you want to think about in terms of selecting the device and the services they provide. As with any new endeavor, there's the implementation. You've got to have leadership and folks to get those galvanizers within your organization to galvanize those to implement the technology. Of course, as with anything else that's reimbursable, you've got to take a look at the revenue cycle and what are your reimbursement as well as your expense sides to the technology or your strategy. And then, of course, leadership has to be behind this and pursue these opportunities to make the most of it.
Thank you, Richard. We've got just a few more minutes, and we did get several questions, and I will mention again, if anybody has any questions, you can send them to events@mcdonaldhopkins.com, or since we're getting to the end of the program, you can also email if you want to. You can email either that address or you can email any of the speakers' addresses here. We've got several questions. One is whether and I'll throw this out in case anybody can answer it or not, but do we have any updates on hospice? And I'm assuming this is relating to hospice, like telehealth care in hospice settings. Yeah, I'll just mention I'm not aware of any. I know there has been some concern expressed on the hospice end about what happens when things tighten up again, and kind of the need for the flexibility to be able to provide the services in hospice. I don't know if there's any other comments on that, but.
Yeah, I really just echoing that. I mean, so for some of the folks, from the wider kind of digital health ecosystem and the community of people that we've been dealing with as we try and advocate to Congress and the agency about the public health emergency and the extension of allowances as much as we can. I'm just having tech issues all over the place. As much as we can enable that extension. I know that what you say is, I couldn't agree more. I think that hospice organizations definitely see the value and would like to be able to enjoy some further flexibility to utilize digital health tools. The fear that I guess I have, if there's any observation, now I can't really, who knows? It's a fool's errand to make a prediction about what the government will do, particularly Congress, right? I can't really count on them to act on anything. There's something of a trend where it's not even just hospice organizations but also some other very important providers like federally qualified healthcare centers and community health centers that have their own special rules, which don't seem to have really been enabled as much as the like the provider community through the regular physician fee schedule was at the time when allowances were widely being made. And so I have a fear that I think maybe it's a call to action. Maybe it's better put that way. Is that there should be a focus on some of these key organizations, including hospice organizations, to enable those allowances for them too.
Those are good points. I think one of the things that raises too is that there's a whole lot of uncertainties as to what happens once the public health emergency ends, and particularly if these to the extent that these flexibilities end. We're pretty much at the end, but I will mention one other question that we got, and we'll see if we can answer it real quickly. Is the question is could we review what is or is not acceptable on patient consent forms as they relate to submitting patient monitoring results for research that must undergo an IRB process? So it looks like this is some kind of telehealth used in or remote patient monitoring in the clinical research. And I guess one general thought that I have there is that it's a little bit hard to comment on that, just because I think you probably have to go back and look at the IRB and the clinical research guidelines in terms of what they're going to require. I mean, it's probably not, we're probably not looking at kind of payer standards there as much as whatever the clinical research study involves. Any other thoughts?
And I agree with what you say, though.
Okay, good. Well, we have gotten to the end of our allotted time. Thank you very much to all our speakers. Yeah, and I will mention again, if anybody has any questions, we're going to be following and reporting on latest developments. In this area, telehealth, remote patient monitoring. If you do have any questions, feel free to email either the address we have on the bottom, email events at McDonaldHopkins.com, or you can email any of the speakers here. Yeah, and certainly any questions are certainly any questions are welcome. Any questions or comments are welcome. And thank you so much for joining us.